Good morning, Matt, and thanks for joining
Good morning.
us today to talk about ACC results. Can you start by kind of setting the scene about, there were a couple late breakers that were presented. What happened at ACC?
There were, yeah. So for the transcatheter valve world and for aortic valve disease, this is one of the biggest meetings that we've had so far. There were two randomized controlled trials presented that looked at transcatheter valves versus surgical valves in patients who are low risk for operative complications. And this is new in the field. Previously we've looked at the extreme risk patients, then we looked at high risk patients, then we looked at intermediate risk patients, and this is risk of bad stuff happening at the time of the surgery, with the idea that transcatheter, less invasive technology might be better with the higher risk patients. And there was some question as to whether or not it would perform as well with the lowest risk patients, or whether we'd really see a difference versus surgery. But what we've learned over the last 7 or 8 years of commercial practice with these valves is that patients really do better after the procedures. They do extremely well as compared to what we're used to seeing with the traditional surgical valve replacement. So this was a really big deal in our field.
Great. Can you kind of talk about what this means for low-risk patients now as far as options expanding?
Yeah, so low-risk patients are 80% of patients with aortic valve disease. 80% of folks with aortic valve disease have low-risk features, so will not have a big problem traditionally thought of as a big problem with surgery. But what we saw in these trials was that the transcatheter valves outperformed surgical valves, and the procedure, transcatheter valve replacement, outperformed surgical valve replacement in just about every domain. So with a balloon expandable valve, we saw stroke rates that were less than 1% less, statistically less and clinically less than surgical stroke rates. We saw a leak around the valve that was almost indetectable with the current generation with sealing skirts. We saw pacemaker needs that were extremely low. We saw patients getting out of the hospital routinely in 3 days and not even needing full general intubation, so just moderate sedation, almost like we do for a stent procedure. So completely revolutionized procedure that is day and night different than a surgical valve replacement. And for patients, this really is a huge deal.
So I know you're a clinician too. Do you expect to see the transcatheter option being used more, being offered by clinicians more?
Yeah, no question. We won't make decisions based on what their risk is. We'll make decisions based on what the patient and we discuss. And we will send, I expect, the vast majority of our patients to transcatheter valves. There are some groups that transcatheter valves haven't been tested in yet, even despite this, and that's patients with bicuspid valves. They've been tested. Bicuspid valve patients, they're just morphologically a little different. They've been tested in higher risk groups, not in this low risk group. So to the extent that you think that maybe the valves perform differently, those data still need to come out, and that is a larger proportion of our low risk patients. So the bicuspid patients, there will still be some question around. And then I think there will still be that kind of back and forth with patients about durability. So there's always the question, you've got a newer procedure, a newer valve, how will this valve hold up over time? And that was addressed actually from the podium at the time of the presentation. I think they addressed it well, which is to say that we like to say that surgical valves have a lot of long-term data. But the truth is, and I've done a fair bit of work in this area, the truth is that surgical valves, really the newer surgical valves, don't have long-term data either. So I don't know that the durability question really plays out quite as much. There will be some patients who are very young, who are 50 to 60 years old, who get this valve disease, who get aortic valve stenosis, who need a mechanical valve. They've got a long expected life ahead of them, and the re-intervention rates would be expected to be fairly high with a biologic valve of any kind, whether it's transcatheter or surgical, and those patients will still get a mechanical valve. But that's going to be the minority of patients these days. I'd say for the vast majority of our patients, we will clinically be sending them through for a transcatheter valve now.
Yeah, and are there any other limitations in the study that you want to talk about?
Yeah, there are a few of them. The study included only 30% women, which is interesting and disappointing. I've spoken with, at least for the balloon expandable valves, with Dr. Leon about what happened with those women, and it's really not clear why it's not a 50-50 breakdown. We know that valve disease does not disproportionately affect men and women, so you would have expected 50-50 randomization rates, 50-50 inclusion rates, and yet again in another study we've seen that women are included less. And this plays into some of the research that we presented at the conference, which is that women are also treated less often when they have this disease process than their male counterparts. Not just treated less, but also treated less with transcatheter valves. What we saw in those data as well was that African American patients, that blacks were treated less than whites in the early periods of our study. That was 2011 to 2014, but in the most recent years, as transcatheter valves have really become an option, that disparity has gone away. So these valves have really started to penetrate the community and our undertreated patients. This is a big day for our field. This is, seeing these results is a really big deal for us and a really big deal for our patients. It's really going to give them an option now to make a choice between, a real values judgment choice. It's going to force what we call shared decision making in this field and the conversation between physicians and their patients. So it'll be interesting. We still need to pass FDA approval and get approved by CMS, by Medicare to bill for it, but as soon as those hurdles are passed, I think this is really going to open up our field.
Great. Well, thanks so much for your time.
Yeah, thank you.